So let's get started. The panel discussion is going to be about premenopausal, hormone receptor positive, HER2 negative metastatic breast cancer. So greetings to you from Bangalore. I'm sure you're familiar with these figures. One is an old founder of the state. He's our Maharaja, who actually ruled, his dynasty ruled for 400 years. And the lower one is the present seat of the government of Karnataka. So these are my panelists. Dr. Prashant Khumbhaj from Jaipur. I don't know how many of them are there, but I will spell out the names. Dr. Chaturbhuj Agarwal from Delhi. Dr. Mandar Nadkarni from Mumbai. Dr. Sumita Jain from Jaipur. Dr. Naresh Soni from Jaipur. Dr. Tarachand Gupta from Jaipur. Dr. Naresh Ledwani from Jaipur. Dr. Manish Chomal from Jaipur. And Dr. Anita Ramesh from Mumbai. So we have a lot of people from Jaipur, as it is. That is the host city for this IBCC. So let's see how we go ahead.
Dr. Govind.
So I have several. Yeah.
Hello. Sir, sorry to interrupt you. Manish Chomal is about to join in another few minutes.
No problem. No problem.
Okay. Go ahead, sir.
Okay. So this is going to be a case-based discussion. So let me present you a 45-year-old woman who presented with a lump in the left breast for about few months with occasional pricking pain and no nipple discharge. She had no comorbidities. She is para 3, living 3. Age at first childbirth was 18 years. Her menstrual history is nothing significant. No history of OCPs and no significant malignancy in the family. On examination, which is important actually, which a lot of our juniors, sadly to say, are missing. The clinical examination, I think it's very, very important. ECOG performance status 1, no supraclavicular nodes, right breast and axilla normal. Left breast shows a lump in the upper, outer, and central regions, measuring 6 into 5.5 centimeters, chest wall not involved, overlying skin is edematous with nipple retraction. The left axilla, there is a 4 centimeter matted group of lymph nodes in the anterior axillary region. So this is the clinical staging for you. These are her baseline scans. You can see the mass, and actually you can appreciate the retraction of the nipple as well there. This is the scan of the abdomen. You can see the liver metastasis that is present. This is the bone scan again showing you the bony metastasis that is there. So what would your management be? So let me call upon Dr. Mandar, followed by Dr. Naresh, to look at their insights onto how you will manage this patient. So this is just to summarize that premenopausal lady, ECOG 1, left breast mass, left axillary node, T4B, N2 MX. So yes, Dr. Mandar and then Dr. Naresh. Is Dr. Mandar there?
No, sir. Mandar sir is not allowed. Dr. Naresh Soni is there.
Okay, yes. Okay, Dr. Naresh Soni.
Yes, sir. Yes, sir. Can
go ahead.
You hear me?
Yes, we can.
Yes, sir. You have already explained the clinical and everything, the imaging also. So first we will go for the true cut or core needle biopsy of the lesion to know the histopathology as well as the receptor status.
Okay. So she's IDC grade 3, hormone receptor ER/PR positive, HER2 negative, Ki67, 32%.
So I will refer this patient to the medical oncologist for the medical management first.
Okay. Sorry, I don't know your specialty.
Sir, I am a surgical oncologist.
Oh, okay. So I pulled Dr. Mandar and you correctly then. So I think we will refer to you for a biopsy. That's all, isn't it?
Yeah.
Okay, fine. So this is how we look at systemic therapy for metastatic breast cancer. This is a slide of 1995 published by Dr. Hatabayagi in New England Journal of Medicine. Essentially remains very similar. Of course, we are now slowly tending towards changing in terms of chemotherapy that is being used, that was being used pretty early on in the disease management. So we'll come to that as we go along. Again, it's important to remember the time-dependent influence of the ER status on the prognosis. And this is just to show you the difference between triple negative and ER positive to tell you that The initial recurrences are very high in triple negative, but they fall off rapidly. But in ER positive patients, the chance of recurrence continues for a very, very long period of time. And I am sure most of us have seen this in clinical practice. That's what is important for us to remember. So, Dr. Chaturbhuj, what is the role of ovarian function suppression in this patient who is premenopausal with metastatic breast cancer?
Am I audible?
Yes, yes, go ahead.
So, sir, we all know that most of the whatever evidences we have that are for postmenopausal females, and for premenopausal females, we actually make them postmenopausal by doing OFS, and then
Correct.
we manage them as per postmenopausal females. So,
Okay.
if you ask me what is the best of this female needs ovarian suppression. And if you ask me what is the best ovarian suppression method, obviously it depends on the patient priority. But I would personally, I would prefer surgical oophorectomy because she is already metastatic. However, if patient is not ready for surgical oophorectomy, then I would say GnRH analog is good enough. However, in this case, if I start with GnRH analog, so then I would be keen in starting on tamoxifen first, and after around 1 month or 2 months, then I would be switching her off to AI based therapy, because we think that ovarian function suppression with GnRH analog will take around 1 month time to means it will not be that one shot of injection and she will be postmenopausal. While if she is going for surgical oophorectomy, then I can start immediately on aromatase inhibitors
Okay.
plus minus CDK.
So this slide actually shows you all the options. As you said, your first choice is surgical oophorectomy. Would you decide it by yourself or would you give the choice to your patient?
So I would give the choice to the patient because
Yeah, fine. Yeah, because your first statement was that you would prefer surgical oophorectomy, so I just wanted to make sure. Okay,
most
so
of the
Dr.
time
Mandar
patient
is
asks.
not there. You have answered part of this. What about Dr. Sumita and Dr. Manish? Has Dr. Manish joined? Dr. Sumita Jain, are you there?
Sir, we have just spoken with Dr. Manish Chomal. So,
Okay.
due to he's stuck in the hospital, so won't be able
What
to
about
join.
Dr. Sumita? Dr.
Sumita Jain is here.
Sumita.
She is here.
Okay, so she can take this question now.
Ma'am, please unmute yourself, Dr. Sumita.
Of course, Dr. Chaturbhuj
She
has
is there.
answered most of it. Yeah, go ahead, Dr. Sumita, please.
So, ovarian suppression by surgical oophorectomy is best if patient chooses use it.
Yeah, go ahead.
Nowadays, laparoscopic oophorectomy is very much possible, and it's almost a daycare surgery.
So you are a surgeon then?
Yeah.
Okay. So yes. So that actually reminds me of a very old slide which was shown by one Dr. Crown in one of the meetings. And he said a multidisciplinary team is very, very important in managing any breast cancer or any cancer for that matter. Because he put a beautiful slide. He says if a patient goes to a surgeon, the surgeon will do surgery. If a patient goes to a medical oncologist, patient will get chemotherapy. If a patient goes to a radiotherapist, he'll get radiotherapy. And the last one was beautiful. He said, if you go to a barber, you will get a haircut. So I think that underlines the importance of multidisciplinary approach. So yes, all the options are there, but I think we are today in a way we are talking about what is called participatory medicine, where you need to get the patient into discussion and see what is the choice of the patient. Our reason is only being a facilitator, give the pros and cons of each of these various modes that we have, and ultimately support your patient with whatever decision that they take. That's how I see it. So my diagnosis about you being surgeon was right. Okay. So this is actually talking about chemotherapy versus endocrine therapy, because we've always, as medical oncologists, jumped to give chemotherapy for premenopausal metastatic breast cancer because we always believe that it's aggressive tumor, you want rapid responses. But today we are actually rethinking what that is. And similar thing was actually there long ago from in this Cochrane meta-analysis published way back in 2003, which actually said that you would have similar benefit with endocrine therapy, and only later you need to look at chemotherapy. Even with the limited amount of chemotherapy drugs we had in 2003, This was the Cochrane meta-analysis opinion. This actually looked at hormone therapy or chemotherapy as first line treatment in various age groups. Now, this is just to show you the difference in ages. The first one is for less than 35 years. This is 35 to 50 years, and this is more than 50 years. And as you can see here, if you look at the time to treatment failure or the overall survival, you can see that you are achieving very similar responses, even if they're very young, whether you use chemotherapy or hormonal therapy. So I think there is a paradigm shift in the thinking of medical oncologists as well today to look at systemic therapy and not really jump at giving chemotherapy for these patients. Also, we have a large number of hormones that are available today. And this is just to tell you that you can use them sequentially. Of course, we need to remember that there is an incremental decrement of the outcomes with what we have. But the drugs that the two earlier speakers spoke about have actually making this not very true. In fact, even with subsequent lines of hormonal therapy, with the newer addition of these drugs, we are actually getting better outcomes. So there enters the CDK4/6 inhibitors, and we all know how they act. We have 3 of them in the market, and there is another one which is in development, which is a parenteral form. So we have the largest experience with palbociclib because that is the one that came in first, and then ribociclib and abemaciclib. So we have all these choices for this patient. So I put in 5 choices here: chemotherapy, aromatase inhibitor plus CDK4/6 inhibitor, fulvestrant plus CDK4/6 inhibitor, fulvestrant alone, aromatase inhibitor alone. So this is for Dr. Naresh. Has he come?
Yes, Dr. Govind, I am Dr. Anita here.
Yes, Anita.
Yes, nice to see you. Thanks to the organizer.
Same here. Yeah.
Yes, for a digital platform. Yes, yeah. And now with the new data coming in, and as we know, this particular patient is not in a visceral crisis. My choice will be after the ovarian suppression is done. Definitely a CDK4/6 inhibitor with an aromatase inhibitor is my first line with the present data.
Okay, right, Anita. Anybody else with a different opinion in the panel?
And also, Dr. Govind, I wanted to add, suppose when I'm in the medical college where resources are limited, a single...
No, we are not talking about resources limited.
Just for sake of completion, point
Correct.
number E can be also a good option. Even point number A when resources are restrained. But
Yes,
ideal
that is
condition
right.
B means the choice might be C also because we are getting more data with fulvestrant adding in.
So why do you believe that you would use fulvestrant in place of aromatase inhibitor?
Yeah, some of the recent studies have also been. Now, another thing, I do keep fulvestrant for my next line because it fails. I will use alpelisib with fulvestrant, which I've done already for a couple of patients.
Correct.
So point number D holds good. That's my first choice.
Right. So there is argument about using fulvestrant earlier. Again, this is sort of retrospective data showing that fulvestrant, when used in earlier lines of therapy, the responses are better. But like you said, we need to have something for subsequent lines. So that is one of the reasons for using aromatase inhibitor in place of fulvestrant in the first line. So this is how the development of CDK4/6 inhibitors have happened. In about 15 years, we've seen such a rapid advances that have happened because of several reasons. One is the drug development and the understanding of the molecular biology of breast cancer. So we have progressed very rapidly with the uptake of these newer molecules, starting with CDK4/6 and now the PI3CK inhibitors as well. So the role of CDK inhibitors. Dr. Sumita, sorry, I picked the wrong person because I was not sure what your specialty was. Anita, so you've already told what CDK4/6 inhibitors will do. And are you there, Anita? Okay, Dr. Chaturbhuj, would you like to take this?
Sir, I didn't got the question clearly. So CDK4, you want me to tell the benefits of adding CDK4/6 inhibitors?
Yes, that's right. Part of it, Dr. Anita already mentioned. So what is your opinion about this?
So I think the standard of care is addition of CDK4/6 inhibitors to aromatase inhibitor is now standard of care, and virtually in both first line and second line setting, we are adding it. If
Right.
we all are aware that PFS benefit is definitely there, and now with ribociclib, Monalisa 3 and 7, we can see some OS benefit also. But
That's right.
I personally would feel that this is a too short time to rely upon this OS, and we need further more OS data with particularly with palbociclib and ribociclib both. So that is
So
means we have.
you're not convinced that the overall survival benefit with newer CDK4/6 inhibitors is good enough for you to start using them. You want to wait
Yes,
for some more
I am
time.
convinced. I am convinced with OS data, but I just want to tell that we need some more data because we are in the preliminary stage only now.
So how
And
much
second thing that
longer would you like to wait for you to get data? And I'm just asking a ballpark figure, just to know, that's all.
so basically, we all are keen in using CDK4/6 inhibitors upfront, because if we delay the treatment, so I mean it's a usual thought that your best player should come first. So
Right.
obviously we are adding it in the upfront setting, and nobody
Yeah.
want to just proceed with A and then wait for CDK inhibitors as a
Fine,
partner
fine.
with fulvestrant.
Right.
So that is the
So
role,
Dr.
I think.
Prashant, I see Dr. Prashant as well. Any
Yes, sir.
comments on this? Yeah, go ahead.
Yes, sir. Dr. Chaturbhuj is saying I agree with him because the data that has shown PFS advantage like CDK4 inhibitor with aromatase inhibitor. So we should use these CDK4 inhibitors with in the front line, and we should keep fulvestrant and alpelisib in later line
No, I'm
setting.
not talking of those. I'm talking of CDK4/6 inhibitors. So
So
do you believe that you are convinced enough with the data that you will use it in first line?
yeah,
Okay.
I'm very much
Thank you.
convinced. Yeah.
Thank you.
Yeah, Dr. Govind.
Yeah, go ahead.
Yeah, there are several trials starting with the three CDK4 inhibitors and enough both in premenopausal, perimenopausal, postmenopausal, and we have OS data.
Anita, I think we no more say call anybody perimenopausal. We only say menopausal or postmenopausal.
Fine, sir. And I think
Yeah,
we
go ahead.
now. Okay, so to bring them in the first line therapy, and we call it a standard of care for these patients with
Correct. So,
this positive
okay, you're convinced then.
Yes.
Okay. Okay, that's nice. So you must be wondering why I put up the east picture here. So I will show you two more pictures which may seem, pardon?
We always enjoy your pictures, doctor.
Thank you. No, this is of some relevance. So next I'm going to show you is a toad. And the third I'm going to show you sea urchin. So you must be wondering why I'm showing you this. So all these three have actually something to do with the molecule that we're talking about, the CDK4/6 inhibitor. In fact, three of these were what actually studied for talking about CDK inhibitors and the cell cycle. And this was done by three different scientists, and all three of them got Nobel Prize for this. So that is the importance of these three organisms for us. We have learned from them, and now we are using it to our patients. So that is how I showed you three unrelated pictures. Okay, now we have three different CDK4/6 inhibitors, and as I mentioned, there's a fourth one in development. Are all these created equal? This is for Dr. Tarachand. Are you there, Dr. Tarachand?
Yes, sir, I am there, sir.
Yeah. So
sir,
there are three of them. Do you believe all are equal or they're different?
Sir, abemaciclib is having a little bit upper age in brain metastatic in condition of brain metastasis.
Okay.
And palbociclib has not shown his OS benefit. But as we see in the clinical practice, there is a very good response rate. Yes, OS data is yet to come. So, and we are having main experience with the palbociclib. But I think there is no much difference between palbociclib and ribociclib. And
Why
for
do you
brain
think
mets,
so?
I will use the abemaciclib for in brain metastatic cancer and with brain mets. Yes.
Yes, Dr.
So
Govind.
you mentioned that there is no overall survival benefit as, yeah, 1 minute, as yet with palbociclib. So do you believe
Yes,
that
sir.
following longer you will get overall survival benefit? Because we've been using palbociclib for quite a number of years now, and we have not seen any overall survival benefit. So how much longer you think you will wait to demonstrate overall survival benefit with palbociclib?
Yes, sir, this has shown with fulvestrant, palbociclib, but not
Overall
in
survival,
AIA.
overall survival.
Yes, sir. Still there is no data of palbociclib.
Yes, that's right.
For
So,
Dr. Govind?
yeah, go ahead.
Yeah, quickly. So almost they are basically almost alike with minor difference. Like rightly
Correct.
our doctor told, abemaciclib penetrates the brain, but there is
Correct.
diarrhea. Okay,
Correct.
and it does not cause neutropenia. Whereas
Correct.
palbociclib, ribociclib, you have to give a gap. There is no continuous dosing.
Correct.
Neutropenia is there, though you may
Correct.
not get febrile episodes. There is, if you are a cardiac patient, be very careful with ribociclib. With the QTC prolongation is there. So we need to just see the comorbidities of the patient and decide the drug and then give it. I
Okay.
think for palbociclib, I'm not sure, but I think some preliminary data for overall survival is also come in a sub-analysis. But ribociclib definitely this data is.
As of now, there is no oral survival palbociclib. I have two comments to make here. Although the slide says with ribociclib, yeah, go ahead.
So similar things are what Dr. Anita and Dr. Tarachand has said. But to simplify things, I think for premenopausal females, we have more data with ribociclib and we have strong data with ribociclib for premenopausal subset.
Correct.
Number one.
Yeah.
Number two, for patients who are elderly or they have deranged LFTs or some cardiac issues, we can substitute or we can prefer palbociclib. I must say we must prefer palbociclib as compared to ribociclib. And considering abemaciclib, there are two specific subset of patients in which I would be happy in using abemaciclib. One, as it has been told by the previous speaker, that patients with brain mets. There are two separate subset of patients where abemaciclib has an upper hand over palbo and ribo. So those two subsets are patients with primary endocrine resistance, where abemaciclib has done fairly better as compared to palbo and ribo. Second thing, patients who has progressed on palbo and ribo. So till now, we don't have any data of continuing CDK inhibitors beyond progression. But yes, abemaciclib can be given to patients who have progressed on palbo and ribo. So these are the two subset of patients.
Yeah,
I think
those are interesting observations. But the first statement that you said is not. I mean, you cannot accept it because those are cross trial comparisons, which are not the ideal one. But with what is available, that is the best you have. But of course, abemaciclib is there. And I think Anita mentioned about QTC prolongation with ribociclib. So this is important, but this QTC prolongation has been seen when ribociclib was combined with tamoxifen, not with AIs or fulvestrant. And the other advantage of abemaciclib is that they have demonstrated single agent activity of abemaciclib, which is not there either with palbociclib or ribociclib. So essentially, the activity is very similar. We have overall survival advantage for ribociclib and abemaciclib. What we need to choose is between the toxicity. So that's how I would see these three different molecules. So this is talking about their responses. The PFS was very, very similar. And now for these two, we have overall survival benefit. So the clinical implications from the trial data, how you can actually extrapolate to your clinical practice. I think now many of us have been using the CDK4/6 inhibitors. So I think we've become more comfortable with use of these. So this is the evidence for you from the Monarch 2, which had abemaciclib plus fulvestrant versus fulvestrant. And again, this was in the premenopausal. And this did show an advantage. And this, I'm sure you recognize her. This is Mona Lisa. And this was the study of ribociclib. And this was published in 2018. I'm also one of the authors because we had quite a few patients from our center. This was the study. I'm sure all of you remember this. The choice was between ribociclib with tamoxifen and or NS aromatase inhibitors. So this study actually showed that the QT's prolongation was a problem when tamoxifen was combined with ribociclib, but not with aromatase inhibitors. And this clearly demonstrated a PFS at that point of time. And now we have an OS and the quality of life issue, which is very, very important. In fact, this is the first CDK4/6 inhibitor that has shown an improvement in quality of life. And now we have data, similar data with abemaciclib as well. So I would like to hear from each one of you about your experiences with CDK inhibitors. Um, Anybody can take this. Anita, I think you have the largest experience with CDK4/6
Yeah,
inhibitors.
not
Can
like
I have your comments first?
Yes, fine. So I do use, I did write for abemaciclib, but then we are waiting for the approval. So I've not used abemaciclib in one way.
Okay.
But palbociclib,
Okay.
ribociclib, I have couple of patients. We do combine with these palbociclib and ribociclib, the patients are basically from the reimbursement sector. So
Right.
while we are able to continue for a long time, relatively the
5 minutes.
drugs are safe. It's just reassurance to the patient, little monitoring of the blood counts in the
Okay.
initially, a relationship with the food, and then later on you need to check the thyroid profiles, ECG, and it's a relatively safer drug to be given, and patient comes as
Okay.
an OP basis, and it's quite a good
Okay.
option. And I
Thank you, Anita.
know
Dr. Tarachand, what's been your experience? Thanks, Anita. What's been your experience, Dr. Tarachand?
Not
Okay,
much
Dr.
experience with
Chaturbhuj?
the
Okay. Dr. Chaturbhuj?
So we had not so much experience with abemaciclib. In fact, when we have
Okay.
used in our trial patients, so there were a lot of diarrheas. With
Okay.
ribociclib and palbociclib, we have very good experience. In fact, with palbociclib, we have just recently published our 208 patients.
Excellent.
We and BLK Hospital with Dr. Amit Agarwal and Dr.
Okay.
Govind. So we have
Fantastic.
combined 200 patients.
Great. I've had the opportunity of working on 2 trials, in fact, 3 trials, 2 with ribociclib and 1 with abemaciclib. And of course, the issue has been the difference in toxicity. So that's how my experience has been. But activity-wise, yes. Of course, palbociclib came in first, so they have the advantage of the largest experience with Indian oncologists. So our patient was explained about the study. She consented to be enrolled. And this is the gamut she got. She got goserelin, letrozole, ribociclib, zoledronic acid, calcium phosphonate, and cholecalciferol. So this is the post-treatment scan, as you can see. And this is the pre-treatment scan of the liver. And you can see the liver lesions that have nicely decreased. This was the first assessment at 12 weeks. So she showed a partial response, and she was continued on this. So we know that resistance to CDK4/6 inhibitors ultimately will set in. Are you there now? Oh, yeah? Okay, maybe I'll ask Dr. Tarachand to take this. What is your impression about the resistance that develops to the use of CDK4/6 inhibitors?
I think that's one of the ways that the patient starts failing while developing the CDK1 resistance to the drug. And now we have the facility also to do the testing for the PI3 kinase. So we can test that. And if there is a mutation there, then we have a drug also to be given. But at this point of time, we always need to do a repeat biopsy in the patient to see the status, do the further molecular, you can run the NGS, you can, and this is also an area where you can use a liquid biopsy. And and these are all expensive drugs, once we are sure that, yes, we are on the right track, we have a drug which will tackle the resistance to CD4.
Thank you, Anita. So, we have primary resistance and secondary resistance, and these are the definitions of these two. And PI3CK mutation is one of the important mechanisms for resistance that we know of. And the other one is the ESR1 mutation. Yeah?
I would
Yes,
differ
Dr.
that
Tarachand.
no, I am a Dr. Chaturbhuj. So Dr.
Yeah.
Anita just said that on progression on CDK inhibitors, we would have to do biopsy. But what actually we can get these mutations, ESR1 and PIK3C mutation testing done on the means on the archival tissue itself. Means we don't need to do any
correct.
biopsy
For the PI3CK mutation, that is fine because it's a truncal mutation. It will be there even in the archival tissue, but not very sure about ESR1. ESR1 can be a mutation that develops on treatment. So for that, you need to do.
But
if it is just for PIK3 mutation, it is fine. But we are trying to see if we have any other newer targetable mutation that is there. So for which I think the fresh biopsy is an ideal thing to do. If you're specifically looking at PIK3, yes, definitely. You can look at archival So back to our patient. She was on the treatment that all of you suggested. She had stable disease as the best response, but after 14 months of treatment, she had increasing back pain. And the scan showed there was mild progression of bone-only disease. Dr. Naresh, are you there? Okay, I think Dr. Naresh Soni is not there.
Yes.
You're there? Okay. So what would you do at this point of time?
Sir, I didn't get your question, please. Can you repeat?
She was on Goserelin, letrozole, CDK4/6 inhibitor ribociclib, and bone-directed therapy. After 14 months, she shows progression of bone disease. What would you do at this point?
That only the bone disease.
Yes.
The distal meds are gone on.
No, they are there. The best response is stable disease for her.
Sir, there is no role of surgery in this patient. So I will again refer to the medical oncologist.
Okay.
Okay,
Yes,
good.
Anita, all yours.
So
Yes, a biopsy if possible. And now this is a resistance to a CDK4 inhibitor. Yeah, if the PI3 kinase is there in the sample mutated, then I would like to add that to it.
Okay, so these are the choices for you. You have actually
I want
mentioned
E.
all of them.
Choice
Yes.
number E.
So you must be wondering what a stupid question I've asked after those two nice talks. But for completion's sake, I had to use these. Okay, so this I think you've already answered. What would you believe is appropriate for mutation testing for PI3CK? At initial diagnosis, using tissue, at initial diagnosis using plasma, at initial progression, and either tissue or plasma. So I think, Anita, you already told that tissue and liquid biopsy are very similar. And I think Dr. Nitesh also showed us that the correlation for both is very good. So if you can get a tissue, that is fine. Otherwise, you can do a ctDNA mutation analysis. So I think
Govind
this
Babu,
we've
2
already
minutes
answered.
remaining.
Yeah, we will finish. So this, you've already seen what Dr. Nitesh showed you when you will do the testing, and this is the recommendations that are there. Like I mentioned, these are generally stable, so you can do it on the archival tissue, but fresh tissue is preferred because you need to look at various other things that have happened during the progression of this disease. And this is again showing you that tissue and plasma are very similar. So now this patient was positive for PI3CK mutation. And so you have a choice of all this. I think we are quite sure what we will do for this patient. And since we don't have time, I will rapidly go through this. This is again showing you the disease-free, progression-free survival when the PIK3 mutation is there versus wild type. This is the data from SOLAR-1, which Nitesh nicely described. And this is the PFS, which was the primary endpoint. And the BILEAF study again, which showed similar efficacy. And this was the real world setting. So our patient was started on alpelisib plus fulvestrant, and she continues to be on that. And of course, she developed hyperglycemia, but I think today we'll not discuss that because Dr. Nitesh discussed these side effects at great detail. And we must remember that we need to rope in an endocrinologist. We must learn from them and we must teach them oncology because that is now becoming a part of the multidisciplinary team.
Yes. Dr. Govind, just one quick comment.
Yeah, go ahead.
Yeah, one patient just it shot up like anything. In weeks, the blood sugar rose. And
Yeah.
luckily, the patient had multiple doctors in the family.
Okay.
Managed before, but it shot up within 2 weeks. It was in 400 for a patient for the normal. But yeah, usually these are manageable things. Yeah, we can nicely manage it if we are oriented and know how to do.
Correct.
And
So you do have a lot of sweet patients, yes.
Yes.
So there are multiple mechanisms of resistance. One of them is the RB1 mutation. Other one is the PI3CK. And there are several others which newer studies within GS are showing up. So I think anybody has experience with PI3CK. I think Anita said she has used alpelisib. So I think we are still learning from it. Anybody having been in a trial of alpelisib or have used extensively? Any comments from anybody who has experience with this?
So we have we have used in 3-4 patients PIK3CA inhibitor alpelisib, but I must say that hyperglycemia is really troublesome. But
Correct.
again, one or two patients, they have tolerated it well and they are doing good. So I
Excellent.
must say that we should use it, and then we should omit for the patients who are not tolerating, rather than deciding
Correct.
that it's a toxic drug and we should
I
not use
agree.
it.
I agree with you because the responses that this has shown is really worth trying for them, worth the risk. Yes. So I think all these years we used to go like this and meet people, but today we are really virtual. I'm hoping that very soon we'll be able to do what I've shown in this picture. With that, I think I must thank all my panelists for their active participation. Thank you very much. I think we have
Thank,
learned quite a bit from each other. Thank you. Thanks, Bharat. Over to you.
thank you, sir.